So Dr. James Teo is a professor of neurology with a special interest in health data, clinical informatics, stroke rehabilitation, general neurology, and brain injury. James is also the joint director of data science and artificial intelligence at both King's College Hospital and also Guy's and St. Thomas Hospital. He's leading development and deployment of Cogstack Clinical Analytics System, which is kind of widely used in many NHSX now across England and beyond. And James is a KCH Investigator for London Medical Imaging and AI Center for Value-Based Healthcare. His work with natural language processing AI has won AI awards from NHSX and has been reviewed by the World Economic Forum. Let's welcome James for the talk. It's quite an interesting topic, and work with real-world data. I hope we enjoyed. James, all yours.
Thank you, everyone. I'm just gonna try to share my screen now. So I'm going to be focused really about kind of how we deploy such systems in the real world and use it in the real world system. So live systems rather than in cold registries or for defined research projects. So going to the next slide. Oops. So I'll be talking about my journey through getting this first started in 2014 and 15, and then gradually getting acceptance of this kind of technology in widespread use, and how I have begun to think about how these tools are useful in the near term. So first things is a very personal journey first, which is basically when we first arrived in 2014-15, you can see we had an overview of the various types of data that may exist within an EHR. This is obviously from an American review. However, in the United Kingdom, it's even more unstructured than this, as it is less insurance-based. And as a result, we have a huge amount of unstructured data in document format, in free text, or semi-structured formats throughout our health record systems, which have been accumulating over the last 20 years. And so this was the issue was facing us. But in addition to that, we also had an issue of data fragmentation even within a single hospital. So while people talk about the fragmentation of data between primary care, secondary care, and social care, we also have an issue internal to these very large organizations in which many systems have come on and off over the years, and many of them are partially integrated, not integrated, or integrated without any, with only minor interoperability. And a lot of this transformation process of the data ends up being quite laborious, so it doesn't get completed, largely because of limited NHS IT budgets. And so as a result, the health record has ended up becoming, certainly in the NHS Trust I've been involved in a tragedy of the common scenario where the data estate is fragmented and the data estate is unsorted. The contents within them are also unsorted. And it's essentially like we've changed from a folder of patient notes to scattering the patient notes throughout many different departments and not being able to necessarily bind them all together easily. A library without an indexing system. So we, as others may have already indicated, and those who have heard my presentation before, is that large amounts of health data is unstructured. The reasoning behind that is some of it is around data standards not having been implemented or agreed on, but some of it is actually a human behavioral factor. Unstructured free text is easy for us to input and easy for us to read. And it's contained in documents and various formats, and it's particular language, and it's very easy for humans to input it when their primary work is not data collection, but delivery of care. and the data record is purely as an aide memoir, so to speak. And so as a result, you may have this bit of text here, which is actually quite dense in information about this imagined patient, but it is actually all hidden within language, and it has all the filters of nomenclature, acronyms, hidden with all the contextual things around negative terms, negations, and family history and such. So as a result, these are the problems we had to address. And so I like to think that I had this grand design right at the beginning, but this is what we've evolved into thinking, is that we first had to reverse the fragmentation process and pool them in one place. The pooling process, we would be agnostic and be accepting of heterogeneous data sources and unstructured text. So one of the issues with pooling data historically has been data transformation. We decided not to do that. We decided to minimize transformation and just pool the unstructured text, and then begin the process of sorting once they're in a big data lake. And this sorting process involves including the metadata, like who it relates to and timestamps and such, but also including other aspects, which we eventually then start tagging with information and semantic information, which we will come to the more interesting NLP and text analytics aspect. And further down on the right, we start using that structured data, the annotated data, and contextualizing it. And so often many projects, not just in text analytics, but research projects in trial healthcare, ends up focusing on the right side of the spectrum, that the researcher is on the right side. And lots of the problems which stop the bottleneck reaching them is actually on the left side. And most of the effort on the left is actually similar across all projects. And so putting that effort right at the beginning helps many projects and use cases and research groups and clinical services. So most of my effort in this has been doing that left side of the diagram, the generalizable bit, whereas the research groups or clinical services tend to be more focused on the right side, and we try to help any efforts on the right side feed into the left side as well. And so this is kind of the thinking on real world, so that we start to think of text analytics as a service for a variety of real world uses. So when we arrived, as I said, we had a very fragmented estate. So the first thing we had to do, together with Richard Dobson at the KCL, we had to pool the data, and we used an open source conglomeration of tools, which we have assembled and released the code for, and we've called them Cogstack. And these heterogeneous systems have all pooling together in that place, and we have a number of microservices which feed that. And the links up there will give you links to the website, the community, and the Git repositories, which are all open. This pooling of unstructured data, so we're essentially bringing it all together. It's all a mess still, but even when you bring a big mess together, okay, you end up with an even bigger mess. That actually has some benefits, even though you would expect that you're actually compounding the problem. Simple things like pooling the data allows us to create dashboards and search free text and keywords, just like you would handle any other structured text. And so we could handle structured data that's in a similar way to unstructured data, and we could generate dashboards like this to measure activity levels in the different work streams. You create geospatial maps to search emergency attendances, plus various dementia suggesting words, and you can create all these dashboards with relative simplicity, even without any significant NLP, just simply by pooling data. We did dashboards, for example, for blood test results and things like that, which are some of the test results often appear in text. And so being a neurologist, I was particularly interested in certain antibody-related tests for uncommon diseases, which were traditionally very hard to query because the results are often hidden away in the free text of a pathology report, because they're quite bespoke tests. We constructed service desks, which then clinical services or service departments or transformation departments in the trusts, who all of them, as you can see, these are the example forms that people of what kinds of requests people had for us. You can see that they're quite varied. This would have been fairly impossible using conventional structured data dictionaries because people hadn't conceived of the idea of some of these requests or conditions within their data dictionaries at the point of collection. But you could do that with text. And here's some examples. And so, you know, that these MOG antibodies, again, some of them had that term hadn't even existed pre-2016. We could search it because someone has used it and that term, and therefore it is searchable. Other scenarios, as you can see here, various other kind of nomenclature that people have used, which we can search, because anything that's represented in language, we can search and service clinical data too. These are some, we can also create alerts. So these alerts kind of sit in the background and wait for that certain trigger words. So in this case, the endocrinologist wanted us to search, to have these searchers which sit and wait for trigger words like insipidus or DTAVP or desmopressin, which trigger every day and to alert their registrar so that they know that someone is doing is considering this diagnosis, or someone is prescribing certain medications, and they can go proactively to find that team and that patient to just make sure that things are in order. So we're moving from a proactive situation rather than a reactive one, waiting for referrals. Likewise, there are scenarios like above in which you're interested in best interest meetings, which again is a bit of a local dialect in terms of what are the best interest meetings for patients with the family. And again, you wouldn't have this in a coded form in any way. And so as a result, we were able to provide this service which supports the different departments and corporate functions of the NHS Trust. And this, as a result, has made it more than an analytics tool for research or academic purposes, but a service that is critical to the business function of a hospital. And this laid the foundations for us to do more, because people began to appreciate the value of what we were doing. We were not in a silo doing things which people felt were irrelevant to day-to-day activity. So that consolidation bit actually did a lot of the legwork for us, and that consolidation bit then allowed us to win supporters and change opinions about how to handle text, which was traditionally been thought as not worthy of handling. So the original way of producing and cleaning data in hospitals has been that doctors and nurses and allied health professionals input data into a paper record, like a folder like that in the big libraries, and then analysts, auditors, clinical coders kind of sift through them and transcribe them onto spreadsheets or case report forms to submit in a structured way. And so this cleaning curation process it's been done since the 1950s and 1960s that way. When we moved to a digital system, we've actually not really changed. We've actually kept that workflow identical to when we were in a paper era. All we've done is changed it replace that paper with a computer, but the process is still the same. That this laborious, what I think the term I've heard is human hydraulic process, where you rely on just large amounts of human transcribing things onto spreadsheets, is still the process in which we handle this. One way that for example, the American model and many of the enterprise EHRs use electronic forms for standardized data capture at the point of data entry. So what happens is that on the left here, where the clinicians are entering, instead of entering it in a free text, they kind of try to enter it into these case report forms, which have kind of detailed drop downs linked to code sets and ontologies, and all very standardized. It's very similar to kind of research case reports forms that are used for registries and trials. And it is also used as a kind of a behavioral nudge to get people to use them as checklists. So you have to fill all these bits before you can progress to the next page, and so therefore you have considered all these scenarios. You have asked the person whether or not they smoke or not, that sort of thing. But unfortunately, the more fields you add, this data depth results in this overwhelming user interface design, like you can see here in one of the leading EHR providers, and you end up with dozens and dozens of tabs, drop downs and menus, and data gets hidden away, and you end up kind of clicking your way, and clinicians end up burning out as a result and losing all the time in data entry rather than delivery of care. And what actually happens in the real world is that people stop clicking. They end up just typing it on the free text randomly. And so our thinking was around changing this model in which we use attacks analytics and more structured data querying and NLP techniques to support that process, which has previously been human powered. And then that analytics and enrichment process would create a bigger lake and a cleaner lake, a data lake, and then this structured data would then be able to feed back into source systems, to clinicians, as well as to other research use cases or population health use cases. So the key tool that we've been developing for this is something called MatCat, which was developed by 3 PhD students in our group, Zelko Kralovic, Tom Searle, and Anthony Sheck. And this is a fairly straightforward open source tool which does named entity recognition. So it detects kind of concept bits of text and attaches them to an ontological concept, in this case, SNOMED, CT, and then provides what we call meta annotations to provide contextual information. So you get whether something is present in a patient or absent in the patient, or whether it relates to the patient or third party, whether it happened now or in the past and such. And we actually, a lot of this happened during COVID, when we had a streaming amount of data in, and we had lots of clinicians who wanted to help us annotate a text, free text for and attach them to SNOMED concepts. As you can see here, there are 4 examples in which people were labeling one for the upper left, COPD for and various airways disease. And initially, a lot of the annotations detected by the NLP was inaccurate, but it rapidly corrected after about 60 or so documents being processed. And we did a variety of different disease areas, and obviously SNOMED is a very large area, and we've been working heavily in producing large amounts of annotations to continuously improve the NLP. This language model, this is probably a little bit old now, but that language model has been optimized in very common high-level comorbidities, but a variety of disorders, as you've listed here, and ongoing annotation in various cancers, dialysis, bariatric surgery, and such. But out of the box, it has been trained on the MIMIC dataset and our entire health record. And so this additional fine-tuning step is an ongoing process, and we are supported by having a large consortium coming on board, including sites in which are operational, as listed here, and sites which are planning to come on board fairly quickly. And we've presented this at the Healthcare Financial Management Association, which apparently is the NHS's professional body for accountants for the NHS. And as you can see, they feel that they can perceive the value on this because it would significantly accelerate clinical coding, data collection, data depth, and all this would also provide greater information for central agencies for planning. The trained models, the models which have been trained on all those annotations, we then we've brought to other hospitals to validate, to see whether or not there are local dialects which affect it, and there are local variations. So if you bring a KCH model, M4 on the upper left, we bring it to UCLH as M5, and if we test it there without any local fine tuning, there is a drop in performance. It's small but appreciable, and then a bit of local supervised training with the MatCat trainer toolset rapidly restores the performance. And so you tune it to the local nuances of language. All this is available in open source, and we have a model sharing agreement so that we can ensure that these these models, as we distribute them, is able to have a track of what they've been trained on, what degree of accuracy they have in certain things, and also to ensure their lineage and their version control. And the idea really being that this would become a community which allows a language AI which is tailored for NHS language. And in fact, because we have, although there are ongoing annotation work, we have taken the most recent version of the model, which has been trained on perhaps about several tens of thousands of annotations. We have actually taken it and run it across the entire record of KCH and GSTT. So what we've done is some of those codes have been validated, some of those codes have not, but it can generate those codes very rapidly with high performance computing. So it took us 2 days to do 20 years of codes for millions of patients. So upper right, you can see all the codes related to outpatient letters, all the codes related to the cancer databases. We can, as we tune it, we can just rerun the model, because rerun the inference across the entire EHR, seeing that we can the availability of high performance computing. And then obviously the final human step, verification step, would then allow it to be entered in as a structured data for other users. And so what we are actually using it for right now is to recycle data from legacy systems into when migrating EHRs or platforms or warehouses. We can obviously feed these codes to registries. We can feed them to research projects. We can feed them to other services as required. And this has produced a very deep phenotype, because these are not just diagnosis codes. These are symptom codes, procedure codes, various anatomical codes in relation to each other. And so this deep phenotyping has, because the human is no longer the bottleneck. The clinical coder or the data entry person trying to read the record doesn't have to only click on a selected list. We can just run it across everything. And so this has become a near real-time process for us. We have, in the same time, been working on NLP for de-identification. I think yesterday we had a preview session with Dr. Kalvik, who presenting some of the work on that. And we've used the same tool with a transformer model to label identifiable text, and then redact them with their category, so that it retains some context. And so we are in a process of validating across several trusts. But as you can see here, we have a Google Colab notebook for anyone who wants to try it. And at some stage, we will be sharing the model in a more open way, so that this would resolve a lot of the manual processes required to redact text. So can we do this in real time? Well, I would say that at this stage, we are not at KCH and GSTT, but my colleagues in UCLH are exploring that. Dr. Anup Shah and Dr. Wei Kyung exploring using this to read the free text and inputting it directly into structured problem lists within an enterprise EHR. This piece of work, I'm sure my colleagues will be more than happy to talk about in a different context. But as you can see here, this piece of work is a big collaboration to try to make it to make things better for everyone. So we've talked about kind of data management at this stage. I mean, it's essentially being the librarian in a library, putting all the books on the right shelf, because everyone has been throwing them on the floor. And that, however, we can now use the text analytics to support that. But we haven't really done anything about insights about healthcare and patients. So as we were doing this, we explore using this in a variety of scenarios. For example, one, we were asked by our palliative care colleagues, our patients, representatives, and our critical care doctors. This was performed during the pandemic, in which they were interested in the language that doctors and healthcare professionals use when describing end-of-life treatment and management plans. And so we use text analytics to generate tokens and as well as word embeddings, and then map them to outcomes over a fair bit of time. And this obviously is a sensitive area, and we had expert patients heavily involved throughout this conversation, and they were actually authors as well in the paper. And as you can see, these are quite these are ecologically, what we would call ecologically valid phrases. These are not what is decided by a Royal College or a standards body. This is what doctors are actually using to describe these things. But obviously, this could also be done on other corpuses of text if we were dealing with specific advanced care plan documents or palliative care documents or mental health documents. You would have a very likely different picture, and it was quite informative in terms of the kinds of phrases that people would use. And we used it during COVID as well for situational awareness. At the beginning of March 2020, we actually had anticipated that as COVID arrived, we would have to be keeping track of large numbers of patients. There wasn't any standardized codes or forms for COVID at this stage. SNOMED had just come out with a SNOMED term, but a lot of the EHRs had not constructed these forms yet. And so we were able to do that by just simply identifying phrases which suggested the person had COVID. At that time, they didn't even have, COVID wasn't even the accepted term. They had various terms like Wuhan virus, SARS-2, coronavirus, nCoV. And so we were able to kind of handle all of them, and we could generate a feed like on the left, the graphs on the left, in which showing the number of documents and mentions occurring over a period of time. And on the upper trace, the line graph, you will see that's the text signal, the signal from the text. And then the area graph below it, just in the same figure, is the actual test results. And actually there's a phase difference in that the text signal preceded the lab results by about 24 to 48 hours, because obviously that's very clear that the symptoms and the differential thought in the person's mind and the doctor happened before the lab is even aware and processing the sample. And this was extremely useful at the beginning of the pandemic when there was a bottleneck with doing tests. And so we were relying on symptom phrases and essentially a EHR Twitter feed, so to speak, of what doctors were talking about. You could also see that this Twitter feed is on the lower blue graph, very sensitive to kind of media. So at the beginning, just for anosmia and loss of taste, as you can see right at the beginning, there was very few mentions of it before the wave hit. Then when the wave hit, there was an increase, but and doctors were detecting were mentioning those symptoms. But then in kind of where the red line is, in kind of mid-May, the Nature Medicine paper came out describing it as a symptom, and then there was an additional amplification of the signal. So this is kind of a media-sensitive signal within the free text, that doctors became aware of it, and they started kind of asking it a lot more and detecting it a lot more. As you can see, we have also started setting up these alerts for monkeypox and various other conditions, and this all sits in the background waiting for things to happen. So this has created a degree of situational awareness and observability of text. And I will like to show you the bonus material if I had time. Yes, I do have time. So we are moving from analyzing text to analyzing patients. So all of those annotations, concepts we detect by named entity, we can actually lay them out in time. Laying it out in time, because they all have timestamps and episodes, and we can map them to the age of a patient. If you imagine each of those concepts as a word in a sentence, then one could use a transformer-based NLP to try to autocomplete a sentence. So in a sense, if that scenario, as you can see above, a patient with a series of concepts, and then you ask, can you try to autocomplete that sentence next? And it suggests an appropriate concept. And we have a preprint on that subject, and we actually have, actually, before I go that, this is just to outline it. We are essentially, the Cogstack pools a document, the MatCat annotates it, and lots of documents within an episode or a particular time point, and into little buckets. And these buckets are all arranged in time. And then this tool called Foresight will then, you can ask it to suggest some diseases, suggest some next symptoms, suggest some medications. And this is at this stage unsupervised. And so I will show you. This is a web app of Foresight at this stage. As you can see, it's been trained on large amounts of data, but it has not been supervised in the sense that it's not been told what the next outcome is necessarily by a human. So this is just a bit of sample text we've taken from the BMJ, but you can type anything you want in there. Like, for example, here, the ethnicities are known, male 25, and this is a bit of free text that goes in, and you can specify whether you want to predict disorders or medications or procedures. So we decided disorders here, and I just click that. And over here, what on the lower right, what concepts it detected in the text, and then it suggests this possible disorders. Likewise, you can just pick another one, and it suggests some disorders. And you can see here, this is with minimal training, but this is the only fine tuning and NLP training was for the named entity recognition, not for the predictive forecasting capability. And these things, this is at the moment we are evaluating its accuracy, and as far as I can say, it's operating at the level of a senior medical student, and it's really quite interesting toy to play with, because not just text, you can I can just change things. He started vomiting blood and dropped and became hypotensive. Okay, and we get to predict that, and bang, it changes it, and then you can see what is perhaps detecting. Okay, and so it's detected the vomiting blood as a variation of hematemesis. And so, and we have a variety of different scenarios, but you can also have it in this what we call a timeline view, where you structure it into a timeline, and that is a bit more accurate because the human language, well, not the English language, is not so great with time, the exact chronology of events. And so a timeline view structures it with the top in the past and the bottom most recently, and you can suggest again what other things worth considering, and you can get saliency on which bit of it is looking at. And so this is, at the moment, we are experimenting with its use in medical education, and possible some sort of digital twin like scenario where you can imagine that being used for considering what would happen if you tried this in this scenario and that scenario. So yeah, so in other demos I've done, I've taken kind of a bunch of kind of suggested creative writing, and people add in sentences that they want in, and then it would try to suggest it. And here, for example, here is a bit of text. I think it's, let's refresh the page. I think it's frozen a bit. Yeah, so a bit of text, and is detecting kind of things that are worth considering. And obviously this is quite a gimmicky, interesting tool. Okay, so bringing it back to the main presentation, we have also been exploring putting these things in graph-based approaches in Neo4j, where concepts are attached to documents into patients. And again, all of this is derived from NLP, annotated text. And so in summary, I would say that in the short term, we just pooling the data using unstructured approaches helps, and enrichment will provide longer term benefits. But even without insights, you don't need new academic insights to necessarily change and improve the functioning of a hospital. But however, you will get it along once you start doing that. The way to get buy-in from the NHS trusts is to embed fully to support trust-wide services and priorities. And these are not, unfortunately, academic or innovative projects, but more of just running a hospital, how to run a hospital. And we have done that, and we have gotten a lot of buy-in as a result. my personal belief is that text analytics will become as ubiquitous as spell checkers. It's in every word processor now. Spell checkers, we don't even consider it as something unusual. I suspect NLP and text analytics will become that state, and to become that, it needs to become part of everyday use. So that kind of summarizes. Oh yes, I've spent some time making a little animation on this because I just was learning how to animate these things on PowerPoint. But yes, this is all the people who have contributed are still working with us. And obviously, we need to thank the important funders, the NHS AI Lab, Health Data Research UK, and patients in our committee. Thank you very much.